Hi, everyone. We'll start in just a minute. We'll give folks a few more minutes to log on. We'll give people about one more minute. So people still logging on, but I think we'll go ahead and get started. So thank you so much for joining us today, to all of those within and outside the nutrition department. If you joined us last night, you heard an amazing talk from our speaker this year, for the really focused on the general public. And this talk today will be more focused on research. So hopefully you'll love hearing the research foundation of the work that's doing. I would like to again thank the folks in this particular setting for their contribution to creating these events. Dr. Linda DeGraffenreid, who's the faculty lead on this event, the members of the Nutrition Graduate Student Association, Matthew Jeans, Dagny Larson, Rachel Rickman, Jesse Valderrama, and Morgan Braden, and also to thank Stephanie Tran for providing all of the support administratively. I am super happy to introduce our speaker once again. We had a great time last night, and I hope that some of you guys are joining us today for the science talk. This is, let's see, I'm sorry. So I'm super pleased to introduce Dr. McTiernan, Dr. Ann McTiernan. She's actually an amazing person. And if you've read her books, you know that she's a woman who never gives up and who's extremely dedicated to her craft. She is a passionate physician scientist, and she is determined to identify how lifestyles like diet and physical activity can influence cancer outcomes. In terms of her academic accomplishments, she received a bachelor's degree in sociology from Boston University in 1974 and a master's degree in medical sociology from SUNY Buffalo in 1976. She went on to obtain her Ph.D. in epidemiology from the University of Washington in 1982, and she worked as a postdoctoral fellow for several years following grad school. And it was during that time that she began to think about becoming a medical doctor. And this is astounding in any case, when you've completed your PhD, to think about another 5 or 6 years of training. And despite being a non-traditional student and a mother of 2, she completed her medical degree in internal medicine from the New York Medical College in 1989. Dr. McTiernan is currently a professor of epidemiology and geriatrics at the University of Washington Schools of Public Health and Medicine, and she is a full member in the Public Health Sciences Division of the Fred Hutchinson Cancer Center. So during medical school, Dr. McTiernan developed a passion for understanding how lifestyle changes could affect cancer outcomes. She has been a pioneer, a true pioneer in women's health research, leading studies that investigate the effects of obesity, diet, and exercise on breast cancer risk and prognosis. Her research focuses on identifying ways to prevent new or recurrent breast cancer with physical activity, obesity prevention and treatment, and chemo prevention. Her ultimate goal is to reduce cancers caused by excess weight and sedentary lifestyle and to improve survival for all cancer patients. And she is a researcher who walks the talk because she incorporates physical activity in her own life and leads by example. She has published over 400 scientific manuscripts, and she's also published several books, including Breast Fitness, which is a roadmap for everybody for how exercise can reduce the risk and occurrence of breast cancer. She's edited 2 state-of-the-art books on cancer prevention and treatment, and she's also published 2 amazing personal memoirs that cover her time prior to becoming a researcher and during the challenges of becoming a medical doctor. And those books will tell you a lot about Ann McTiernan because she's an open person who's willing to share her own personal stories. And again, she's dedicated to improving cancer outcomes. So without further ado, please help me welcome Dr. Ann McTiernan.
Okay, good afternoon, and thank you so much to Dr. Bray and everybody else that has invited me for this to talk with you today. For those of you who saw my talk yesterday, I'm going to be presenting much of the same studies, but in much more depth, because I understand this is a group that is in research, that has or is teaching research studies or is studying. So what I want to see if I can get my screen going here. There we go. Okay. So I'm going to talk about weight control and exercise for breast cancer prevention. And I know a few people are in your program are interested in cancer survivorship and doing research in that area. And so I'll include a little bit about that as well. And what I thought I'd cover is some work to look at the totality of research. Looking at results from a compilation analysis done with the World Cancer Research Fund and with the U.S. Physical Activity Guidelines Committee. I want to cover mechanisms because that's something I love doing. I do studies in humans, experimental studies in humans. I'll talk a little bit about future research needs as well. And one of the important reasons that I'm presenting data from that has been looked at in totality, like from meta-analyses, large group analyses, the efforts to look at the totality of research, is that in epidemiology and in other fields, you really can't learn everything by looking at just our own studies. We really need to look at what's going on in total to know the science, to know what the biology is, and also then eventually to come up with guidelines for people to follow for optimal health. So first, I'll talk about World Cancer Research Fund meta-analyses. So meta-analyses, we do these in epidemiology, is when you look, you do a systematic review to find all published studies in epidemiology on a particular topic. In this case, on body mass index or weight or other measures of weight and breast cancer risk and prognosis. So you do a full search on that, and then using particular statistical tools, take the resulting estimates, the effect estimates, and usually it's a relative risk. I'll explain what that is too. And then compile that into one summary statistic so that you really can see what's the effect, in this case, of body mass index on breast cancer risk across all the studies that had data that could be compiled into one estimate. So I showed this figure yesterday, and I'll go over it again today. But this one, or a related figure. In this one, with the World Cancer Research Fund, and I was part of a panel that reviewed their data for them. They compiled the information from all this available studies that had data that could be added together on what's the association between breast cancer risk and increasing body mass index levels. And they divided the breast cancer cases into those that develop before menopause and those afterwards, because those are, in many cases, can be considered different diseases. The prognosis may be different, the way they're treated may be different, what the tumors look like may be different. So epidemiologists often tend to divide breast cancer into what occurred before a woman's menopause versus that after. So each of these different squares refers to the relative risk. That's the risk in one group versus the risk in another. In this case, it's the risk in increasing levels of body mass index compared to the lowest level of body mass index. And each of these refers to a particular study. So Bandera would be the first author. It was published in 2015. The square is the relative risk. Some of the squares you can see are large, and that means they were larger studies. Smaller squares were for smaller studies. The relative risk is indicated over here. So the relative risk of 0.97 means that the risk of developing breast cancer before menopause was actually lower in women as their body mass index increased. So relative risk under 1 means it's decreased risk. Relative risk above 1 means it's increased. These numbers in parentheses are confidence intervals. So there's just a statistical test of how likely we, or how confident we are that the relative risk lies within that range. You see there are, when you look over at the plot, you can see there are lines around the square. If they're very large, like say this study down here, very long confidence interval. Typically that happens when you have a very small study, and the statistics show that there's less confidence that the relative risk is around where the square falls. So combining all of these risk estimates from all of these studies, we come up with this what's a little diamond here, and I say dazzled by the diamond because that's the summary. That tells us what we saw through all the studies in total. And so the summary statement we would say about this is that for premenopausal breast cancer, for each 5 kilogram per meter square increase in body mass index, the risk of developing breast cancer is actually decreased by 7%. So 1 minus 0.93. So what about postmenopausal breast cancer? Same type of forest plot. In some cases, same studies, just dividing the cases into pre and postmenopausal women. But when you look at the summary statistic, adding all those data together and averaging them, it looks like there's a 12% increased risk of breast cancer for each 5 kilogram per meter square increase in body mass index. And so as nutritionists, you know that people's body mass index can get quite high. So if the lowest body mass index level that was used across these studies tends to be in the low 20s, by the time a woman gets up to the body mass index in the 40s, her relative risk is going to be quite high. So you multiply these relative risks and you're going to be getting quite high level of risk. These studies had enough information that for some of them we're able to look at separate subcategories. Breast cancer is for many women is a hormone-driven disease, and for about 70% of cases, about half of cases, depending on the woman's age, the breast cancer is estrogen receptor positive. That's the tumor that's shows estrogen receptors on it, and it's measured in all women and men in a way to determine what's the best treatment. So estrogen receptor positive and progesterone receptor positive, these tend to go together, but not always. You can see the greatest level of relative risk, 17% increased risk for estrogen receptor positive, 47% increased risk for progesterone receptor positive. And again, this is in postmenopausal women. And for those who are both, almost 30% increased risk. These relative risks are about 1 or a little less than 1, showing much less effect of body mass index in other types of breast cancer. Postmenopausal women are often using hormone therapy, at least in the past. About half used to be using them. It's much less now. But one question is, if women are using hormone therapy, is their obesity going to affect them at all? And it looks like for those who were currently using hormone therapy, there was not an increased risk with obesity. But for women who either never used hormone therapy or previously used hormone therapy, there was increased risk, about 20% increased risk. Waist circumference is another measure of body fatness, and you can see those relative risks. So comparing to the lowest level of waist circumference, and this is about an average for each of these 4 categories, relative risk really doesn't increase very much. But in postmenopausal women, you see that relative risk for each category. These are quintiles, up to a 35% increased risk for those women who have the highest waist circumference. And remember, the waist circumference is a measure of general body fatness around the mid area, depending on exactly where it was measured. But it represents both subcutaneous fat and visceral fat, intra-abdominal fat. And for some diseases, visceral fat is really important. For breast cancer, we think it could be either, because subcutaneous fat contains more of the enzyme aromatase that converts pre-estrogens into estrogens. So I'm going to get into later how estrogens are important in obesity. What about weight gain? Well, most people that end up have in their middle to later years having high levels of body mass index do that by gaining weight. And so you can see if you have a cohort of women, so on average, these were multiple cohorts of women that the cohorts had available several different time points of weight measurement. And if over the woman's lifetime she gained 30 kilograms or more, she has about a 50% increased risk of developing breast cancer. What about weight loss? And some of these studies did have enough measures of weight that they could look at whether women were had lost weight over a period of time. For premenopausal women, it looked like those who had lost any amount of weight had a 15% decreased risk of developing premenopausal breast cancer. And this for the same measures, those who had lost any amount of weight over their lifetime had about a 10% decreased risk of developing breast cancer after menopause. So interesting, even though obesity was not a risk factor, it did not increase risk of premenopausal breast cancer, there's still some suggestion that weight loss was protective for both younger and older women. So what about physical activity? So one effort I was involved with was looking with the US government on a committee that's similar to the dietary guidelines committees, but this is focused on physical activity, and it occurs every 10 years now instead of every 5 years like the diet guidelines. And our committee wanted to look at cancer as one of our main topics. And we asked ourselves several questions. One is, what is the relationship between physical activity and invasive breast cancer? We wanted to see effects of dose response. So with more exercise, do you get more benefit? We wanted to look for all cancers at the effect of gender, race, or ethnicity. And for breast cancer, we did consider whether the results are seen in men too, but there are very, very few men that develop breast cancer, so there wasn't good data there. We wanted to look at specific cancer subtypes and also persons at high risk for cancer. The committee also looked at what's the relationship between sedentary behavior and invasive cancer incidence. And then similar to what was done for the previous effort I mentioned, the World Cancer Research Fund, we did systematic literature reviews, and these were done by the government, by their contractor. And we decided that because of the massive amount of data available, we would be focusing on systematic reviews, meta-analyses, pooled analyses primarily, and these are for published data. We primarily looked at prospective cohort studies because that's most of where the data were. And for our efforts, there were no randomized clinical trials that we could look at in terms of looking at effect of physical activity on developing a cancer. So in terms of prevention, we had 9 systematic reviews and 4 meta-analyses and 2 pooled analyses. So what's the difference between a meta-analysis and a pooled analysis? A meta-analysis is where the researchers look at the data that are presented in a published report, relative risk typically, and then confidence intervals, and then averages those. A pooled analysis, on the other hand, is where investigators send all of their data, individual level data, to a central depository, and then somebody, typically an epidemiologist or a statistician, works with those data and then can use the same types of measures, classify the physical activity and other measures in the same way, and then come up with a combined estimate of effect. The types of physical activity we looked at were recreational, occupational, and household. Some studies looked at total physical activity, but almost all physical activity that was measured across these studies was aerobic activity. So we really don't have information on resistance. The meta-analyses estimated met hours per week if data were available. So that's the intensity of exercise by amount of time exercised. And typically, because many studies used different categories for what they considered or how they classified physical activity, whether they classified it into quintiles or quartiles or smaller groupings, or used a continuous variable, they were still often varied across populations. So the cut points for highest versus lowest physical activity did vary. What did we find? Well, for breast cancer risk associated with physical activity, we included meta-analyses and pooled analyses that were published more recently, and that some of those studies included between 4 and 80 source studies. Some of them included only cohort studies. Some included both what's called cohort studies and case control studies. Most of them were looking at leisure time activity. They all looked at dose response. So that's the question of, if you exercise more, do you get better effect? And some of them were able to look at subgroup effects. So we'll go over those a little bit. And what did we find? So we saw that looking across the studies, when exercise was categorized as highest versus lowest, that's very crude categorization, but that's the best you can do often in a meta-analysis. But what these studies found that was a 12 to 21% relative risk reduction with highest versus lowest level of physical activity. We found strong evidence that there was a dose response effect, and that there was no threshold. There was no lower limit beyond below which exercise had no effect. When we looked at body mass index, so one question is you're going to see the same effect by level of body mass index. And we did see a suggestion that the effect was greater in women who were lighter weight. We weren't able to look at specific age groups, but we did see similar effects in both pre and post-menopausal women. We tried to look at race and ethnicity, and we decided there was limited information on that. We also looked by at histologic type. There was limited information. We couldn't make any summary statements about that. We looked at women at high risk. That was also limited. We found there were really only 3 studies that had been done in that to answer that particular question. So we didn't come up with any summary statement on that. In terms of sedentary behavior, so the one question is, our culture is becoming so much more sedentary. Is the sedentariness causing an increased risk of cancers, in this case, breast cancer? And another question is, can physical activity overcome sedentary behaviors? We reviewed 3 meta-analyses with both control and case control studies included, and we determined that there really wasn't much evidence of a relationship between sedentary behavior and higher risk of breast cancer. But it's still an active area of research, and many epidemiologists are starting to look at this. Our guidelines committee decided that there really was insufficient information about breast cancer associations to come up with an exact dose of exercise to recommend. So our overall recommendations mirrored what the general physical activity guidelines are, which are 150 to 50 minutes a week of aerobic activity, and less time if an individual chooses to do vigorous activity. We decided for all of these other things that I've listed here that there really was insufficient information to talk about particular subgroups. So I won't go into that in detail. What about prognosis? So I'm going to do this pretty quickly, but I know there's some people that are interested in cancer survivorship, so that's why I'll do this. Back to the World Cancer Research Fund, we did look at what happens in terms of prognosis for a woman who has breast cancer, and we have enough information about her, either her physical activity level or her level of obesity. In this case, I'm talking about her level of obesity. So when we do a meta-analysis, this is for women who've already developed breast cancer, you do a meta-analysis of what their weight corrected for height was at time of diagnosis, and then categorizing as high versus low levels. We see there's about a 27% increased risk, relative risk was 1.27, increased risk of total mortality, an increased 35% risk of increased risk of breast cancer specific mortality. And in most cohort studies, about half of breast cancer, half of the deaths that occur are in breast cancer, and the other causes of death for women with breast cancer are things that are causing deaths in the general population. Luckily, breast cancer is a highly survivable cancer nowadays. So many of these cohorts really had to be followed for decades in order to be able to see these statistics. We see for total mortality, you see increased risk for both premenopausal and postmenopausal. Surprisingly, you also see some increased risk for women who are underweight. So that's body mass index under 18.5 compared to normal weight women. Trying to move up my screen here. There's been one effort to look at effect of weight gain in women after menopause, and these are all individual studies. And there's some suggestion that just moderate weight gain after diagnosis, about 5 to 10%, does not increase risk. Hazard ratio, similar statistic to relative risk, was really not increased. But there is some increased risk with high level weight gain. So a woman develops breast cancer, increases weight by more than 10% of her starting weight, may have a 23% increased risk of dying of breast cancer or another cause. The survival from obesity, women who have obesity compared to normal weight women, is reduced and is shown in both hormone positive and negative breast cancer, pre and post, and women with other specific cancer types. I won't get into that here either. Women with obesity have higher risks of wound complications from surgery, lymphedema, higher risk of cardiotoxicity if they're treated with some of the medications that can cause cardiotoxicity, and certainly increased risk for many other conditions that people without cancer also have increased with obesity. Well, are there any studies ongoing? So I'm just going to quickly go through a few things that are going on in the cancer population. There was a clinical trial in women with breast cancer. It's called the WIN study. Women were randomized to either a low-fat diet program or to a control program. And after 12 months, the women with a low-fat diet program had lost about 6 pounds greater than women in the control group. And after 5 years of follow-up, the risk of death was significantly reduced by 24% in diet versus control. There was a similar study that occurred at the same time that found no effect. There are ongoing studies looking at weight loss and risk of dying or at invasive disease-free survival. And so I don't want to spend much time going over these because I'm going to take too long, but just so that you know, there's one in the United States that's recruiting over 3,000 women. There's one in Germany that would be a similar size, and there's one that's a little bit smaller going on in Italy. So the results of all of these won't be available yet, but it's promising that there's ongoing effort to determine if weight loss can improve survival. Physical activity, back to what we looked at with the US physical activity guidelines, looking at, again, observational studies. It's not clinical trials, but in observational studies, we determined there was moderate level of evidence that there's a reduction in risk of all-cause mortality and breast cancer specific mortality. These levels of reduction are quite high, so we weren't sure that that was really, that the effect is that high, but there probably is some risk reduction. I'm going to skip now to talk about clinical trials that we've done to look at mechanisms. So these are small clinical trials I'll talk about to look at what could be the effect of either exercise or weight loss on things that could be related to breast cancer. So looking at this is a kind of a complicated slide here, but what we hypothesized is that weight, excess body fat, low physical activity may be causing several biological effects that could fuel breast cancer. And I alluded to the fact earlier that estrogens are important with breast cancer. So it turns out in cohort studies of women without cancer, if you measure their blood estrogen levels when they enter a cohort, those with the highest levels of estrogens have increased risk of breast cancer. The same thing with androgens like testosterone. Women who have high levels of insulin, who have high levels of insulin or glucose, or who are pre-diabetic or diabetic, have increased risk of breast cancer. Women with high levels of inflammation, high inflammation measures such as C-reactive protein and some other interleukin measures have increased risk of breast cancer. There's some suggestion that angiogenesis is important that can be angiogenesis markers that can be measured, as well as oxidative stress. So what we wanted to do is to look at what happens if you do an intervention and get people to change their behaviors, get them to be physically active, get them to lose weight. Can you see effect on these biomarkers and others? So I'll talk about two different trials. We first designed a trial to just look at the effect of exercise. What's the effect of exercise in postmenopausal women who have overweight or obesity. So we randomly assigned 173 sedentary postmenopausal women who had overweight or obesity. We randomly assigned them to either exercise or to a stretching control group. And their goal exercise was 45 minutes a day, 5 days a week. And our main endpoints for that trial were sex hormones and other breast cancer biomarkers. Then the second trial I'll talk about is called the new study. There we randomly assigned 439 sedentary postmenopausal women into one of 4 groups, either a dietary weight loss program that was based on the diabetes prevention program, or the same exercise program we used in the first study, in the PATH study, or a combination of both, or a control group. And our goals were to look at the same types of biomarkers. The first study, our exercisers, we did very well. Well, first, only about 2 women dropped out of the study. This was a year-long program. They met 80% of their goal. And what happened to their biologically? Well, they increased VO2 max, cardiorespiratory fitness, by 13%. So that tells us, on average, they were exercising. They decreased fat mass overall and intra-abdominal. This we measured with a DEXA scan. Intra-abdominal we measured with CT scan. Estrogens decreased. So the estrogens included estrone, which is the most common estrogen in postmenopausal women, and estradiol, that's considered to be the most active. Those decreased by 12 to 20%, but only if their weight decreased or if their fat mass decreased. Insulin resistance decreased, and this is again the exercises versus controls. C-reactive protein, a marker of inflammation, decreased, but only if the fat mass decreased. We found decrease in several markers of oxidative stress, but only if they were exercising at the highest level. So we had several markers of angiogenesis that we later measured, and those decreased, especially with fat loss or with increasing VO2 max. And then I won't get into some of these others, but I do like to point out that other things that we measured did not change. Insulin-like growth factor didn't change, telomere length and DNA damage did not change. So once we saw that exercise worked, but only in women who lost weight, we thought, what would happen if we really get women to lose a significant amount of body fat and weight? And so we designed a trial to add to this results of the first trial, but this one was to add in a dietary weight loss intervention. So I mentioned before, it was a 4-arm study, and these are our primary endpoints. Later on, with additional funding, we looked at several other biomarkers. This was a 12-month trial. Of postmenopausal women, the same type of woman as the first study. These were just all of their eligibility criteria. So they're randomized into almost 4 equal groups. So we got a little bit of power benefit by having more women in the interventions than in the control group. And as you can see, our adherence and our retention to the study was not quite as good as the first, but it was very good for a weight loss study. So we lost about 10% of the group by the end of the year for dropouts, but it was similar across all arms of the study. The exercise intervention was the exact same as the first one, so I won't go into that. But overall, the women also met 80% of their targeted goal. Our diet program was based on the diabetes prevention program Look Ahead diet. And the goal there was 10% weight loss by 6 months, using a calorie deficit depending on starting weight. We suggested they decrease their calories from fat as a way to reduce calories. What we thought was very important, we gave all women 2 to 4 individual sessions plus group sessions that were first weekly and then monthly. We had facility weigh-ins, and then we had the women weigh themselves at home at least weekly. And then we had them complete daily food logs for at least 6 months. And the women who weren't doing well at 6 months, we asked them to continue that. But this was one of our main predictors of how well women were meeting the dietary weight loss program. And on average, the women attended a mean 91% of their sessions. So this was just showing you baseline values. So on average, the women did have obesity. They tended to be non-Hispanic white, looking like the Seattle population at that time. They tended to be unfit and to have a high level of body fat. And we did lose 9% of the women by 12 months. So what happened? I'll show you a series of studies, slides showing our results. So similar to the diabetes prevention program diet on which this is based, we saw about a 10 to 11% reduced weight at 12 months in both the diet group alone and the diet plus exercise. The control group didn't really change their weight, and the exercise only changed only a small amount. Well, looking at this, I'm going to show you a lot of slides now that show results. So compared to control group, we see significant changes in estrone. That's the most common estrogen in postmenopausal women, so it's a good one to measure. See a little bit with exercise only, but mostly the greatest effect with both diet and exercise. So a lot of these pictures are going to look the same because that's where we saw our most effect, the combined program. Estradiol, the most active estrogen in postmenopausal women and thought to be most related to breast cancer, definitely see over 20% decrease in the combined program. Testosterone decreased, and testosterone levels are also associated with risk of breast cancer. Smaller effect size, but definitely see a significant reduction. What about by weight? So when you do a trial like this, not everybody is going to lose the exact same amount of weight. So we categorized into the groups into the control group, those women in the intervention who had lost less than 5% of their starting weight, and those who lost more. And you see across the board, regardless of which intervention people were in, those who lost at least 5% of their starting weight had the greatest change in estrone and estradiol. Almost the same picture here. So just losing 5% of starting weight or more, they lost 25% of their estradiol levels. Insulin change. This is something that's not new. It's been shown in a lot of other trials, but we've confirmed it, that diet programs do significantly decrease levels of insulin. And this was an interesting result because C-reactive protein is a really strong predictor of risk for cancer. It's a good marker of general inflammation. We saw a 47% decrease in level of C-reactive protein in the women in the combined diet and exercise program. And that's better than any medications that I know of that are used in the general population that might decrease inflammation levels, like statins or non-steroidal medications. We also saw just a summary of some other things we did see were decreased with the dietary weight loss groups, including other measures of insulin resistance and other markers of inflammation, angiogenesis, and oxidative stress. And we saw some increase in several markers. But again, I'd like to also present things that had no effect. So we found no effect on insulin-like growth factor from either weight loss or exercise. We measured telomere length and saw no effect there. We looked at DNA damage repair and it showed no effect. In a subset of women, we're able to look at DNA methylation and showed no effect. And then in a small subset, we measured adipose tissue gene expression and showed just minimal effect. So I didn't show that here. We're interested in the long-term effects of these interventions, and we couldn't get NCI funding to continue the trial. And so we didn't have consent when the women entered the study to do long-term follow-up. But with some small pilot studies, we're able to ask a subset of women if they would be interested in coming back. So at 30 months post-randomization, so about 2.5 years after randomization. So not everybody came back, but some did. So you know that those who choose not to come back could have quite a different experience, but we were still interested in what we would find at that point. And what we've found is that women continue to have increased sex hormone binding globulin. So what is that? That is a protein that binds both estradiol and testosterone to then control how much of those two hormones are available in the tissues. So higher sex hormone binding globulin is going to bind up the estradiol or testosterone and then make it less available to tissue. So we consider that to be a good thing in terms of breast cancer. So at 30 months, that was still high. Adiponectin, which is another adipose hormone, was high. Insulin remained decreased, but we saw no lingering effects on any of these estrogen or androgen measures. Some of the additional things that we're working on are looking further at exercise effect on adipose gene expression, on microRNA related to adiposity and cancer. We're looking at weight loss patterns and changes in cancer biomarkers. And then we have an additional trial that I mentioned yesterday, where we're looking at acute effects of exercise on breast cancer biomarkers. So let's see how my time is doing. I think I'll skip over this because I talked about it yesterday, but if anybody has an interest in learning what this new trial is, it's ongoing, then I can certainly talk about that. But just like many of you that are doing research, COVID was not kind to us. We did have to stop recruitment at various points, and recruitment was slowed down. So luckily, the foundation that's paying for this has allowed us to continue. So we'll just be delayed. We'll still be able to do our trial. It just won't be done as quickly as we thought. So, excuse me. In summary, then what we are, let me see what other summaries I have. I'll finish here. So we find in summary that with increased body mass index, we see increased risk of postmenopausal breast cancer, increased risk of mortality. We've seen that high levels of physical activity are associated with reduced risk of developing breast cancer and reduced risk of mortality. Our human experimental studies and others do support biological effects of weight loss and physical activity relevant to breast cancer. And we do see dose response effects, so more exercise, more weight loss seems to be better. And there's some hint of long-term effects. I want to just thank that and recognize that much of the studies have been funded by the National Cancer Institute, the Breast Cancer Research Foundation, and Fred Hutch. And in epidemiology, there are typically thousands of investigators involved with various studies. So we really can't name all of them. That would take up an entire day, but this is definitely a group effort. And then I'll finish with our picture of Seattle. And this is the Fred Hutchinson Cancer Research Center right in the foreground here. And in the background is Mount Rainier. Thank you.
Thank you so much. That was a wonderful talk, Dr. McTiernan. We'll open it up for our question and answer session. So if you have questions, pop them in the Q&A button down at the bottom of your screen. And then if you go there, you can like different questions that you want to see answered. We have about 10 minutes to answer questions. Okay, so we have our first one. When discussing your literature reviews, meta-analysis for physical activity and breast cancer prevention, you mentioned self-report was used to denote physical activity. Did you think this may have affected results?
Yeah, that's a great point, epidemiology is relying on self-report for both physical activity and for weight, height and weight for measure of body mass index, as well as waist circumference, with some exceptions in terms of weight. But if you have error, so that introduces error of all types into analyses. It can be random error, it could be systematic error. But what that does is that it minimizes the relative risk. So the effect sizes that we saw today are likely underestimates of true risk and true protection.
Okay, and a second part to that, does the literature also show studies with other collection methods for physical activity?
There are very few, typically the physical activity is gathered in terms of how much somebody was doing. There are different ways of doing it. You can ask people to complete logs, or you can ask them, give them a list of exercises and see, do you do these? How often do you do them? Some of our studies have been interviews, some have been self-reported forms, some of them have been some of the more standard ones like the International Physical Activity Questionnaire, but they all have some amount of error. There are very few studies that have looked at accurate, more accurate objective measures, and some of the cohort studies are starting to do that. There really has to be an investigator that involved with the study that has such a high level of interest in exercise that they're willing to put aside that amount of effort into it, because it's quite expensive to accurately measure levels of exercise. But still, you still see signal even with the amount of error that we see in physical activity questionnaires.
Okay. Do you think that the epidemic in childhood obesity is going to impact breast cancer incidence in the next decade?
Certainly it could. If we have higher levels of obesity in middle to adult levels, and one of the biggest predictors of future behavior is current behavior. So children who have obesity are more likely to be adults who have obesity. So that could be affecting it. I did present data on premenopausal women that had obesity as young women, so maybe that reduced the risk, but it's going to be pretty much a mixed picture of whether weight can protect younger women, but whether that added weight that women are going to carry over their lifetime, is that going to continue to fuel their breast cancer?
Yeah. For the 30-month follow-up to the new study, did you see that weight loss was maintained in those that had increased sex hormone binding globulin and decreased insulin?
I can't remember. We did publish on that, but I can't remember what we saw.
Okay. Based on what you've seen in your studies and evidence of resistance exercise benefits, what do you think the effects of resistance exercise would be on breast cancer risk?
I think we just don't know. All of those epidemiology studies relied on what people said they were doing. And typically, if there were women that were doing resistance exercise, there was such a small number that they would have just been added together into the larger group to look at a total measure of like physical activity minutes per week or med hours per week. So teasing apart the effects of resistance is going to be very difficult. Most of the studies on resistance exercise have been these small human experimental studies.
What are your thoughts on the particular diet approach used for weight loss? Your intervention studies have used a generally healthful diet, but what are your thoughts on high-fat diets for weight loss?
Yeah, it's a great question. To my knowledge, it's not been looked at in terms of these breast cancer biomarkers. Certainly, we see comparison studies of weight loss, and you do see similar weight loss with low-carb diets. And to my perspective, it's mostly the amount of calories that lower calories, you're going to see weight loss. But and these are such new diets. I don't know if there's long-term effects, long-term studies looking at the effect of these on future development of disease. But you know, I think weight loss is the key. And the other thing that hasn't, I talked about a little bit yesterday, but it hasn't been looked at for long-term weight loss and effect on breast cancer, or weight maintenance and effect on breast cancer, are the various medications that have been looked at. They're with, as you'll know, bariatric surgery is one method of producing very large amounts of weight loss. And to my knowledge, there's only one trial that has looked at endpoints and what they've found is that diabetes risk, it decreases significantly. But all the other studies are comparison studies. They're prospective cohort studies that are not randomized trials. To any of the short-term trials that could be looking at estrogens or cancer biomarkers, to my knowledge, they haven't, and that could be because the women getting bariatric surgery often are in the younger years. They may be premenopausal or perimenopausal, or if they're postmenopausal, they were previously taking hormone therapy. So it's a very difficult group to study in terms of looking at these hormone endpoints.
Yeah. Is there any research regarding weight loss by bariatric surgery and effects of exercise?
Yeah, so within the bariatric surgery community, is there effective exercise? I don't know. I couldn't answer that.
Were you able to see if any medications that modulated inflammation, such as NSAIDs, or modulated insulin IGF-1 signaling, impacted the effects of weight on risk or outcome?
I'm pretty sure that in our, we published in Cancer Research on the results of weight loss and exercise on inflammation markers. And I'm pretty sure this is a postdoc who led that. I'm pretty sure she also did look within those who were using non-steroidals or statins versus not, and didn't see a difference.
Okay. Where does pregnancy breastfeeding fit in with all of this research? Has timing of weight loss before pregnancy or breastfeeding and associated changes in breasts been considered?
Yeah, I don't know if that's been looked at. It sounds like a very good question.
Okay, given the differential impact of diet more rather than physical activity on breast cancer risk, what is the rationale to continue to dig into physical activity through your current intervention trials?
Well, there's still an interest because weight loss is so difficult, and long-term weight maintenance is difficult. There's still some interest in, is there something that could be have an effect? And the parallel for physical activity, the reason we wanted to look at acute levels is that we know even in people who have obesity and diabetes, that physical activity can have some acute effects that can be helpful. And we know that it can lower blood pressure, and it works in people of different body size. So if you can see in a human experimental study like this, if you can see an acute effect on biological related biomarkers related to cancer, that could give a little bit of hope to people who are struggling to keep the weight off, but are willing to put some time and effort, or want to put some time and effort into physical activity. I think the bottom line is both keeping weight off, keeping in the normal range, and keeping physical activity is going to be the best for health overall and for reducing risk of breast cancer. But it's not always as easy to implement.
Yeah. In your clinical trials, did you look at circulating free fatty acid levels or triglyceride levels?
We did look in the past study, we looked at some cardiac related measures, and we did see, we published on it, I can't remember what we saw. It was a long time ago.
Okay. And I think that was our last question. So I want to thank you again for coming to speak for us. And nutrition students, you'll have a Q&A with Dr. McTiernan to ask more questions in just a few minutes. Otherwise, have a great weekend, everyone. Thanks again for coming. We hope you join us for more Department of Nutritional Sciences seminars.
Thank you.